Thank you. So we're gonna hop over to Sina for the scientific perspective. In the interest of time, sorry, Sina, I think you don't need much of an introduction, but so Sina is our resident expert in tissue engineering and regenerative medicine, and he has designed and developed a whole array of innovative smart biomaterials. I won't get into all of them, but they're very, very impressive. And without delaying much further, Sina, we'll hop right into your presentation.
Thank you so much, Natalie. So can you see my presentation, everybody?
Yes.
Okay, perfect. So I'm going to skip some of the introduction as Natalie mentioned. Thank you, Dr. Latska, for great clinical perspective. So I'm going to talk a little about the basic science and the mechanism of action for the monocyte-rich PRP in combination with the concentrated protein. So up to today, most of our conversation is around the PRP have been cell-centric. We focus on the cellular fraction of the blood, including platelet, different leukocyte, and in some by formulation, even a small flash of the red blood cells. But PRP is essentially, by its name, platelet-centered biologic. Once those platelets are activated and degranulated, they release a cocktail of the cytokine and chemokines and growth factor, things like PDGF, IGF, VEGF, EGF, and interleukins. But depending on how we formulate the PRP based on the inclusion or exclusion of the leukocyte, different types of the leukocyte, we can get the regenerative, reparative function of the PRP or anti-inflammatory function of the PRP. However, in our blood, beyond of the cellular fraction, we have actually protein fractures and also small molecules. And with the current system, current setup of the centrifuge-based preparation method, we cannot isolate the protein and small molecules. Actually, if we want to get the protein and small molecules, our RPM set up for the PRP for the centrifuge should be over 20,000 RPM and with very high G-force. And with that G-force, actually we damage the cellular part of the blood. So actually, when we prepare the PRP, specifically in the double spin system, after the second spin, we are going to have platelet poor plasma, which is enriched with the small molecules, protein, and we only take a portion of that for suspending our Buffy code, and we actually discard the rest of the platelet poor plasma or PPP, which is the which is enriched with the platelet, with the protein and small molecules. However, we need to consider that we need to know about the component in the PPP. In the reality, the PPP is about 90%, 91% water, 7 to 8% protein, and the rest is the other soluble molecules. Actually, 22 most abundant protein in our plasma represents approximately 99% of our total protein mass in our body and can be categorized under one of these categories as functional plasma protein, tissue leakage protein, which usually indicates the disease state, and also signaling proteins can be hormones, growth factors. And so we usually don't consider them because we cannot isolate them just with centrifugation. However, with the new technologies as ultrafiltration system, now we are able to actually recover the protein part and add the protein fractions to the PRP by formulation. As you can see, this is the M-side core filter system, and we can already use this system to wash out the platelet poor plasma, which contains 90% water. And based on the pore size of this filter, we could remove the protein with the size smaller than 20 kilodaltons, which is mostly contain the inflammatory cytokines and retain everything bigger than 20 kilodalton in a size. So as you can see, when we attach the syringe contains the platelet poor plasma, first we need prime the filter and then attach another syringe. So the important trick in this system is applying a vac lock syringe and apply the negative pressure to make the process easier and faster. And you can see when you apply the negative pressure, eventually it's going to be very smooth for you to back and forth, and eventually your volume could be decreased and the water goes through the vac lock syringe, and you're going to have the concentrated plasma, which is enriched with the essential protein, and we're going to talk about later in our next slide. Okay, so when you have this concentrated plasma, you could use and return it back to the PRP kit and resuspend the PRP buffy coat, which you collected at the bottom of the uh, kit, bottom of the tube, and resuspend the buffy coat with the concentrated plasma instead of the platelet poor plasma. In this way, you are gonna make the protein-rich PRP. And regarding to the bioformulation of your PRP, you actually choose the bioformulation by inclusion or exclusion the leukocyte during the first and second speed. So in the both cases that Dr. Latska explained, we actually use the protein-rich, monocyte-rich PRP with this system and method. So, as I mentioned earlier, we have a bunch of different proteins in our plasma, and I already listed the proteins as our target. Actually, we tested the recovery of them in our lab, and so you can see the concentration of them in our blood plasma is very, very in a good level, and with the concentration 4 times, 5 times, we are going to have even more. The function of these proteins are already mostly anti-inflammatory, anti-protease, or even some of them as the regenerative and reparative as a structural protein, we can use the benefit from them. I already put the 10 targets here, except one of them, which is the TNF alpha, as inflammatory protein, and I wanted to test how our system can remove the most of the inflammatory protein. Other 9 proteins we actually received, and we actually got very good recovery percentage with the core filter for these proteins. The things you should notice in this table is the size. Except the TNF alpha, which is below 20 kilodalton, and we expected that to remove the TNF alpha and most of the inflammatory cytokines, their size is also their size are also below the 20 kilodalton. We have IGF-1 with the size around 7 kilodalton. But in reality, in our bodies, some of the growth factors, some of the proteins like IGF, they already are bound to other carrying protein. And with this system, we can retain them because the actual complex size is going to be over 50, 60 kilodalton. Why IGF? Because today IGF is one of the most interesting targets for a longevity field. And actually now we are receiving the data in the basic science preclinical studies that IGF can help mitogenesis, biogenesis of the mitochondria, and it could help for inflammation, subsiding the inflammation, and so on. I didn't actually include the rough data for the recovery because we haven't published them, and very soon you are going to have that publication in the literature. So since the A2M is the key player and the famous one, we are going to go over the mechanism of action for the A2M. It acts as a broad protease inhibitor trapping the enzymes such as MMPase, matrix metalloproteinase. and preventing the excessive degradation of the extracellular matrix, either collagen in the tendon or the collagen and ECM for the cartilage. So far, most of the conversation about around the A2M focus about the anti-protease activity, but A2M also can reactivate and potentiate the growth factors, which they usually have very short bioavailability, because the mechanism to minimize the bioavailability of the proteins and growth factors usually in our body is phosphorylation. A2M can bind to the phosphorylated part and actually inhibits the phosphorylated part function and recover the actual function of the protein or growth factor. For example, for IGF, we have very short half-life, and also it gets phosphorylated, but A2M can help to recover the function of the IGF. Also, A2M has that ability to act like chaperone proteins and helping stabilizing the misfolding proteins and preventing their aggregation, which support a cleaner environment for tissue repair. Actually, in osteoarthritis, mechanical wear and aging push chondrocyte into hypertrophic state where they release cartilage breaking enzyme like MMPase, as I mentioned, and damaging signal like DAMPase. These signals activate synovial cells, which then secrete TNF alpha, interleukin 1, interleukin 6, and more MMPase, creating chronic inflammatory environment that accelerate the cartilage and bone damage. A2M actually binds these cytokines and protease, trapping MMPase and ADMHTS, and make a cage for them and helping to break matrix breakdown and protect the cartilage surface. As Dr. Lotzka mentioned, we don't have that much clinical study regarding to the A2M, and hopefully in next 2 years we could have better data, because now using the collecting data platforms, we are recording the data, we're collecting the data, and the combination of concentrated protein or A2M with the other modalities like PRP and bone marrow, and hopefully we could get better clinical data. So far, we have a few clinical studies. One of them is actually this study. It started at 2013 and updated in 2024. They actually compared the efficacy of the A2M compared to PRP standalone and corticosteroid for 75 patients. And after 12 weeks of follow-up, they already reported the comparable efficacy of the A2M compared to PRP and corticosteroid for mild to moderate knee osteoarthritis. But we usually use the A2M in combination with the PRP, not a standalone. Another study, actually the intradiscal injection of the A2M to determine the ability of the autologous A2M to relieve the back pain. In this study, 40 patients already were enrolled, and finally, after 6 months follow-up, the data was available for 24 subjects, and the patient outcome shows both pain relief as VAS score and functional score improvement for the intradiscal treatment with the A2M. Another study used the A2M for as a novel treatment for patients with chronic pelvic pain syndrome. In this study, 19 patients received approximately 5 ml of the A2M, again, a standalone for each patient, and pain and function were assessed via VAS score and also functional pelvic pain scale. As you can see, in most of the criteria, we have improvement with the A2M. And the last study I included in this slide, it's a case series report which described the successful treatment of the A2M for neuroma pain for a 30 years old female patient with amputee. The patient underwent 2 sessions of the A2M treatment 2 weeks apart, and actually patient reported significant pain relief, and ultrasound showed decrease in neovascularization and cross-sectional area for neuroma, and the efficacy of that treatment long lasted for 2 years. Another actually interesting protein we need to consider eventually because the concentrated plasma is not just A2M, and A2M is not the only player, is the serpin family. Actually, in our body, we have 36 different serpin as a serine protease inhibitors, but the 30 member of this 36 family, actually, they are anti-protease, and they are the biggest natural anti-protease community in our body. So, as you can see in this cartoon, in our plasma, actually we have the serpin A1 and serpin A3 as the most abundant one among others, and also our chondrocytes can produce that. And one of the marker we could find as the initial step of the osteoarthritis is a little elevated level of the serpin A1 and A3, like A2M, as a natural response of our body to the injury and to the osteoarthritis. Same as the A2M, when we have the inflammatory condition for our joint, for our cartilage, our chondrocyte start to release that, and or if we apply as exogenous concentrated protein, which has the serpin A, serpin A1, A2, A3, and others, they can actually inhibit the activity and inhibit the protease activity, specifically in this case, leukocyte elastase, and inhibit the interleukin-6, TNF-alpha, and other inflammatory mediators. Regarding to the serpin A1, there is only one preclinical solid study. They actually use the serpin A1 as a treatment for both intra-articular injection and also for systemic administration for both mice and rat model. And they saw that serpin A protein can reverse the joint inflammation, nociceptions, and cartilage degradation. And also, ex vivo analysis of the arthritic joint revealed that the serpin A1 can downregulate MMPA13 and ADAMATS5 gene expression. As I mentioned on that table, and I showed you, we have other proteins, not just the anti-inflammatory and anti-protease protein. We actually have a structural protein like fibrinogen and fibronectin. The most benefit we can get from the high concentration of the fibrinogen after activation of the platelet coagulation cascade, changing the prothrombin to thrombin, and cleavage of the fibrinogen toward the fibrin, we are going to have a kind of mesh and a 3D matrix that helps to have the sustained release of the growth factor and a kind of a scaffold for soft tissue. So when we use the concentrated protein, which is not just A2M, that specific protein as fibrinogen here could help in this way for both cartilage in the joint and soft tissue as a tendon. Another protein is going to be the fibronectin. Fibronectin is famous as adhesion molecule, adhesion protein, and studies showed when we use the fibronectin for the cartilage, it helps the progenitor cells to attach and move toward the defect. Also, the same scenario for the tenocytes and tendon progenitor cells to have better organization and regeneration with the fibronectin. Also, when we apply the fibronectin in a joint, we could get the benefit of the lubrication with the fibronectin. Albumin is the most abundant protein in our body, and as it acts as one of the most potent antioxidant. Most of the inflammatory condition, we can see the footprint of the oxidative stress and ROS and NO2. So with the albumin, we actually have a very potent antioxidant, and also we can get the benefit of albumin as a carrying protein since we have a bunch of growth factors with very short half-life. Having the albumin, it could help them to have longer bioavailability and bioactivity by encapsulating them. And the last protein I'm going to talk about is the ApoA1, which is a protective anti-inflammatory protein for knee osteoarthritis. Actually, one cohort study of 184 patients showed higher ApoA1 level in synovial fluid were linked to less cartilage damage, lower KL grade, and better WOMAC. So it has the same actually mechanism for anti-inflammatory action by reducing the TNF alpha and interleukin 1 in multiple inflammatory disease, including the osteoarthritis. So we talked about the monocyte reach, and Dr. Latska mentioned the monocyte reach. We talked about monocyte reach before in our previous webinar, just to remind, when we have the monocyte, the high concentration of the monocyte alongside with the platelet, actually platelet can give signals to them. And in this case, we are going to have mostly anti-inflammatory monocyte, and monocyte can be differentiated toward mostly anti-inflammatory macrophages. So that's why when we have the PRP as monocyte PRP, since we have the platelet, high concentration of the platelet, with the monocyte, we are going to have more and better immunomodulation properties from the monocyte-rich PRP. And also the rationale to combine the monocyte-rich PRP with the concentrated protein. As we mentioned, different types of the protein, not just A to M. We could get simultaneously anti-protease activity, anti-inflammatory activity that helps the immunomodulation, and also some structural properties of the concentrated protein, like the benefit from the fibrinogen and fibronectin, and also anabolic properties of the IGF-1. For IGF-1, we need probably another session of the webinar because it's very, very huge information behind of the IGF-1 now. So for tendinopathy and tendon injury, same concept and same rationale. We have with the monocyte reach, we can change the chronic inflammation and irritation toward the better calm situation. And also one thing in soft tissue, we usually need angiogenesis, organized angiogenesis. Before we use the neutrophil reach, but neutrophil is a gas on a fire, and we don't want to use that for chronic inflammation. And also, if we include the neutrophil in our PRP by formulation, we actually diminish the benefit of the anti-protease and anti-inflammatory of the concentrated protein. So we don't want to combine them. So we prefer combine the monocyte rich with the concentrated protein to get the benefit, and also for soft tissue, get the benefit of the angiogenesis and vasculogenesis. And for the rationale behind of the concentrated protein for soft tissue and tendon, similar to the joint, but in this specific tissue with the a structural protein like fibrinogen and fibronectin, we can get the benefit of the scaffolding from them, and we can get better organized collagen 1 synthesis. So thank you so much for your consideration.